So I'm Dr. J Lakhani, and today we are mainly going to focus on when and how to prescribe an SGLT2 inhibitor with DPP4 inhibitor combination. What kind of patients would you prescribe this medication? What type of combinations are available and which of these are good combinations to use? And what are the benefits of using this combination in clinical practice? So that is what we'll be focusing on mainly in today's talk. Now, let me first divide and tell you which SGLT2 availables are SGLT2 inhibitors are available in India and which DPP4s are available in India. So, if you talk about SGLT2, we have empagliflozin, which is available in India, and you have DEPA, which is available. You also have CANA available, and you have remogliflozin available. So you have these types of SGLT2 available in India, and you have in terms of the DPP4s, you have linagliptin, you have sitagliptin, you have vildagliptin, and you have tenaligliptin. So these are all kinds of DPP4 and SGLT2 available in India. Now, when you are talking about SGLT2 DPP4 combination, some of these drugs are combined together and they are available as a combination. So you have EMPA and LENA, which is available as a combination. You have SITA and DEPA, which is available as a combination. There's one more DPP4 we don't talk about much is sexagliptin. So you have a DEPA and sexa combination also available in Indian market. You have Vilda being combined with DEPA. So you have a Vilda DEPA also combination available. You have, we have Remo with Vilda also available, which I don't think not many people use it. But I think the major, and I think now we are going to have a LENA and DEPA also combination also available. So these are some of the combinations available. But mainly in terms of clinical practice, the combinations that we commonly use are EMPA plus LENA, and this is the most commonly used drug which we use. Nowadays, of course, we also have DEPA and SITA, which is becoming quite popular. And then you have a DEPA with LENA, which has just come recently, which we may or may not be using it much, but I haven't used it much. But these are the two, and especially EMPALINA is the one which we use most commonly in clinical practice. Now, let's take a case scenario and try and understand which type of patients would you consider prescribing this DPP4 SGLT2 combination. So let's take a clinical case patient. So you have a patient with type 2 diabetes. So let's say you have a patient with type 2 diabetes who is, let's say age of the patient is 50 years. Now, let's say patient has a history of coronary artery disease, had a myocardial infarction maybe 2-3 years back, right? His HbA1c is, let's say, 8.7%. His fasting sugar is, let's say, something around 150. Post meal sugar is, let's say, 210. Okay, so this is a typical profile of a patient. Besides that, let's say you have urine albumin-creatinine ratio, which is in the range of somewhere around, let's say, 50. Okay, so this is a typical, let's say, typical profile of patient who presents to you, right? Now, let's assume that the patient is already on metformin given in dose of 2 grams a day. Okay, so this type of profile of patients, let's say you have this, and we typically see some of these patients in clinical practice, right? Now, what can you do to add to metformin? Okay, so what are the options you have? So patient is already on metformin. So what can you do? So you can add a sulfonylurea, right? Maybe glimepiride or gliclazide. You can add a DPP4 alone. You can add SGLT2 alone. Or you can add a combination of these two, or some people would probably also consider adding something like a acarbose or voglibose, right? So AGIs can be added. Okay, so these are some of the things. Obviously, you will not use pioglitazone in this patient. Why? Because patient has history of coronary artery disease. So again, in terms of a patient with, well, generally you can actually give it in a stable CAD. But generally, especially patients with heart failure, you should probably not give pioglitazone. So these are the things, right? Now, if you give sulfonylurea, it will reduce the HbA1c about 1%. Okay, Of course, there are other drugs you can use, GLP, insulin, other things, but practically speaking, these are the things you should be using. So you use sulfonylurea, it will reduce the HbA1c close to 1%. So our patient has HbA1c of 8.7%. You reduce it to 1%, it will be 7.7%, and our target is less than 7%, right? In most of these patients, right? So we are, sulfonylurea is not going to be enough. Then let's say DPP4 inhibitor, right, which will reduce the HbA1c by 0.5%. Clearly, it's not going to reduce enough. Let's say you add SGLT2 alone, great choice, but HbA1c reduction will be again close to 1%. So from 8.7, you reduce to 7.7 again. Acarbose AGI will probably reduce HbA1c about 0.5 to 0.7%. So again, it will not be enough. So what about combining these two agents, right? So you add a SGLT2 with DPP4 inhibitor. So patient is already on metformin, but you add SGLT2 with DPP4. So 1 plus 0.5, it will reduce the HbA1c by 1.5 to almost 1.7% in some cases, which will reduce the HbA1c down from 8.7 to 7.2 or even less than 7%, right? So this is where, just purely in terms of the blood sugar reduction, remember DPP4 SGLT2 combination like EMPALINA is a single drug. You are giving a single molecule, right? So with the single molecule, you are able to control the patient's blood sugar very easily. Okay. So what kind of medication and what doses are available? So you have EMPA and LENA, in which you generally have EMPA in dose of either 25 milligram with LENA in dose of 5 milligram. This is a common combination which is available. As far as DEPA and CETA is concerned, we generally have DEPA 10 milligram plus CETA 100, which is typically available, or you have 5 with 50 also, which can be given twice a day, but this is the one which is generally used. So this EMPA 10, 25 plus LENA 5 and DEPA 10 with CETA 100. These are the common combinations that we use. Now this EMPA, you can also have 10 milligram. So you have 10 milligram plus 5 milligram. So you have EMPALINA 25 by 5 or 10 by 5, which are available. When do you give this medication? This is to be given OD once a day. I generally give it before breakfast, right? So you just have to give once a day. You can in fact give it any time of the day. There is no relation with meal, but typically we give it first thing in the morning. So, you have the effect lasting for the whole day. So this is the type of patients where you consider using a EMPALINA combination. So if you see in terms of guidelines and in terms of a more practical thing, this is published in Diabetic Therapeutics in 2022. So they said that have a patient who is where can you consider giving a EMPALINA combination. So you have a patient where you first initiate, of course, lifestyle measures, and the patient will be on metformin. If let's say the patient is a treatment naive patient where no treatment has been given and where metformin for some reason is contraindicated or not tolerated, and the HbA1c is more than 8%, you can directly start the patient on a EMPALINA combination or a DPP4 SGLT2 combination, and directly your HbA1c, remember, your HbA1c reduction will be 1.5%, so you'll come down easily to less than 7% easily. Now, if you have a treatment naive patient already on metformin, then typically HbA1c close to 9%, you can easily give this combination. And patient who is uncontrolled on metformin therapy, which like the kind of case we saw, again HbA1c more than 8.5%, you can consider giving this SGLT2 with DPP4 combination. Then of course, let's look at why this combination is very effective. So one thing we already saw in terms of the HbA1c reduction. Now HbA1c reduction we already saw will be reduced to somewhere by 1.5 to 1.7% HbA1c reduction you get with this combination. Second advantage, it's once a day, so very convenient for the patient. It's a powerful drug which can be given once a day, right? So that's another advantage which the patient gets. Thirdly, it acts on multiple pathways in terms of diabetes, right? So this is what we'll see here. So we all know the omnious octets. Omnious octet is a situation where Dr. DeFronzo says that there are 8 different pathophysiological processes which are involved in diabetes, which lead to diabetes. So this is the omnious octet, right? So you have first of all, of course, reduced insulin secretion. You have the decreased incretin effect. You have increased lipolysis. You have increased glucose reabsorption. You have decreased glucose uptake in the muscle or in the adipose tissue. This is peripheral. This is called peripheral insulin resistance. You have neurotransmitter dysfunction. You have increased hepatic glucose production, and this is called central insulin resistance, right? and you have increased glucagon secretion, which is also part of the process. So all these things are the 8 different pathophysiological processes that lead to that contribute to diabetes. Now, of these, you can see multiple of these, many of these factors are actually impacted by use of a DPP4 SGLT2 combination. For example, the increased glucagon secretion is suppressed by use of DPP4. The decreased insulin secretion. Obviously, there will be a little bit of insulin secretion by DPP4. It's mainly post meal, but it's not going to be much. But this effect is very important. The incretin effect is obviously very important. You have glucose reabsorption, which is controlled by SGLT2 inhibitors. So this will be effective. So they think this and this. These are the 3 very important parts of the omnious octet, which are going to be impacted by use of SGLT2 DPP4 combination. So I think that one of the biggest advantage you get with this combination is that you can actually target multiple pathways, and because of that, the patient has a lot of benefit. Fourth is cardiovascular benefit, CV benefit. I think this is also, we'll discuss this in a few minutes in more detail, but you have cardiovascular benefit. You know that SGLT2 inhibitors have cardiovascular reduction in cardiovascular mortality. Whereas if you talk about linagliptin or let's say sitagliptin, these gliptins tend to be cardiovascular neutral. In fact, linagliptin itself is completely safe in a patient with a cardiovascular disease. So these are the cardiovascular benefits. More importantly, you also have renal benefits. I think this is one of the major advantage, especially of EMPALINA combination. I think this is a major advantage of EMPA-LENA combination. So both empagliflozin and linagliptin individually reduce the urine albumin-creatinine ratio. They reduce the urine albumin-creatinine ratio and they protect the kidney. So I think this is one of the major advantage of this combination in practice, that they reduce urine albumin-creatinine ratio and protect the kidney. And finally, one reason, I'll again discuss this in more detail, but when you give this drug in combination, we know that SGLT2 inhibitors produce genitourinary tract infection, but when you give this drug in combination, there is reduced genital tract infection. The genital tract infection risk is reduced because of this combination. I'll tell you the reasons why this happens in a few minutes, right? So you have multiple pathways of the omnious octet which is affected, and you can see here SGLT2 and DPP4 both are complementary in terms of its action, and both tend to be very effective in this. I think one very interesting thing I'll tell you, which if you see in terms of glucagon. Now in diabetes, what happens is that there is a defect in glucagon also. So there is in fact increased glucagon secretion. So both these drugs have a opposite effect in glucagon. So SGLT2 inhibitor typically increase the glucagon, and DPP4 inhibitor would suppress the glucagon. Okay, so some patients with SGLT2 inhibitor are at risk of diabetic ketoacidosis or euglycemic diabetic ketoacidosis. That is mainly driven by the glucagon axis. So you have this insulin glucagon mismatch. Remember this concept. Always remember this concept. When do you develop diabetic ketoacidosis? When you develop diabetic ketoacidosis when you have less insulin and more glucagon. This is a very, very important fundamental concept which we all need to understand. So when you have less insulin and more glucagon, you develop diabetic ketoacidosis. If you just have one of the two defective, it will not develop decay. So for example, you have, or let's say you're both defect. So let's say you have less insulin and less glucagon. This happens in which patients? It happens in patients with pancreatic diabetes. So when you have pancreatic diabetes, which is also known as type 3C diabetes, right? In these patients, you have both insulin, which is less, and glucagon also less. So these patients require insulin, but they don't develop diabetic ketoacidosis. Whereas type 1 patients, right, or some type 2 diabetes patients develop DKA because they have less insulin and more glucagon. So when you give this drug in combination, SGLT2 increases the glucagon, whereas DPP4 reduces the glucagon. So when you give this in combination, the risk of euglycemic ketoacidosis is also less, right? So you have less risk of euglycemic ketoacidosis or diabetic ketoacidosis is reduced with the use of these combinations. I think that's another advantage of use of this combination in clinical practice. Another very important concept which I would like to propose to you is the concept of disease modifying anti-diabetic drugs. Now, in my opinion, anti-diabetic drugs can be classified into two types of groups. One is the group which just reduces the glucose values, right? But doesn't impact the underlying disease. So underlying disease, it doesn't have much impact. Whereas you have the disease modifying anti-diabetic drug. These are the ones which not only reduce the glucose, but also fundamentally change the underlying disease, right? Change the underlying disease. So there are a few drugs which can be classified into this category, right? And there are few drugs. One, SGLT2, which produce weight loss, also change. There are a lot of fundamental changes which it does, right? Similarly, you have GLP-1 receptor agonist. This is also, I would classify as a disease modifying anti-diabetic drug. So these two for sure. To some extent, metformin and also pioglitazone can be considered into this territory, right? Whereas drugs which just mainly act on controlling the glucose, these are something like DPP4, insulin, sulfonylureas. So these are the agents which mainly act on the AGIs on reducing the glucose level. Both are important in practice, but these do not fundamentally change the disease. So by giving SGLT2 with DPP4, you are doing both. You are getting a disease modifying drug as well as a DPP4 inhibitor, which has effect on the glucose lowering. Okay. So then next question a lot of people will ask is that, are we allowed to give combination therapy in clinical practice? Yes, we are allowed. If you see, this is a recent ADA guideline. ADA guidelines also recommend use of combination therapy wherever it is feasible. So you should consider, especially those patients, they've said that should be considered. When should you give combination? You should consider in patients with HbA1c more than 1.5 to 2% above target, and you need to give drugs with high glycemic efficacy, and so that is something. And the underlying disease, if there are some other drugs, you need to probably modify according to that. So according to ADA 2023 guidelines, you can prescribe combination therapy, reduces the pill burden and improves the patient's outcomes, right? So it is a thing, right? We already discussed some of the benefits of SGLT2 with DPP4 combination, but this benefit I specifically talked to you about. So this is a meta-analysis by Fedini, which looked at the risk of developing genitourinary tract infection in patients on SGLT2. And what they found was that patient on SGLT2 with DPP4 inhibitor have less risk of genital tract infection compared to a patient on a SGLT2 inhibitor alone, right? So this is called a forest plot. How do you interpret this forest plot? Let me just tell you. So this is the central line, okay? So anything which crosses the line, right? In this case, for example, this is crossing the line. This is not statistically significant, but if it is on one side of the line, it is statistically significant, right? And you can also see the relative risk over here, right? So you see the confidence interval, right? So if the confidence interval is only on one side, for example, it's less than 1, or if it is more than 1, then that means that it is statistically significant. Whereas if it's crossing, right, it is between less than 1 and also more than 1, in that case that is not statistically significant. So you can clearly see individually this one study actually showed statistical significance, but when you do a meta-analysis where you combine all the data, you have statistical significance. So that means that the confidence interval is 0.28 to 9.92, which is all less than 1. That means that giving this as a combination, when you have studies done, multiple studies, and you do a meta-analysis, you found that there is a reduced risk of genital or genitourinary tract infection, right? Now, why does this happen? There are two theories for it. One is reduced glucose load, and second is fundamentally at the fungal growth level, right? So there are two theories. The first theory is, and this is a theory which is that, whenever you reduce the glucose load, so any kind of anti-diabetic drug you give along with SGLT2, if the glucose load is reduced by the second drug, the risk of genital tract infection is lower with the use of SGLT2. So for example, what this theory suggests, that let's say you give insulin with SGLT2, then you have less genital infection than you give SGLT2 alone, right? So this is something which is a fundamental concept. Secondly, so obviously you are giving a DPP4 SGLT2, that means you are reducing the risk of this genital infection. Secondly, some people believe this is also that the use of DPP4 inhibitor, actually fundamentally there are certain enzymes in their DPP4 enzymes in the fungus also, and which are necessary for the growth of fungus. And by giving DPP4 inhibitor, actually you are reducing the fungal growth per se, because you are interfering with these enzymes in the fungus, right? So that's why these two theories suggest that you have less genital tract infection when you give a combination of DPP4 with SGLT2 inhibitor. Okay. So finally, overall, I talked to you about this very important thing, that is ASCVD risk factor. So remember, SGLT2 inhibitor has been known to reduce ASCVD, especially empagliflozin, which you have very good data. It typically reduces the risk of coronary artery disease, reduces the risk of the patient developing heart failure and hospitalization for heart failure also. So these are things which are benefited. So overall, just to summarize from a SGLT2 DPP4 perspective, what type of patients would you give a SGLT2 DPP4? Any patient, typically you have a patient with HbA1c more than 8.5%. Without any contraindication, you can give this drug, right? Secondly, you have a patient, what are the advantages of giving this combination? So you have, you have a very efficient drug which you are giving, right, in one pill. So it's once a day medication, very easy to prescribe, and you have HbA1c reduction of close to 1.5 to 1.7% HbA1c reduction. Thirdly, you have cardiovascular and renal benefit. And the side effect profile also neutralize each other. So you have less genital tract infection and less risk of diabetic ketoacidosis. So all these things are beneficial, and it covers more aspects of omnious octet. Right. So this is about giving SGLT2 with DPP4 combination. Right. Now, the next point is that what about specifically in terms of the combination in terms of EMPALINA, right? So this study where they found that if you give EMPA and LENA in combination, you can clearly see that HbA1c reduction in patients who are drug naive, not on metformin, HbA1c reduction is close to 1.9%, whereas patients already on metformin, you have 1.6 to 1.8% reduction of HbA1c. Okay, and you achieve the early. Not only is this effective, but also the achievement of the HbA1c target goal is as much as within 12 weeks you'll achieve the HbA1c target. Okay, right. So let's look at the cardiovascular risk point of view also. This already we discussed, right? That when you give this combination, you have cardiovascular benefit. Also, you have other benefits. You have empagliflozin reduces the weight. You have the reduction of systolic and diastolic blood pressure also. You can see this chart where you can see that there is CV risk reduction with the EMPA trial. It's also applicable in Asian patients also. So there's significant reduction in Asian patients also. In fact, 56% reduction in Asian patients. So Asian patients actually had more benefit in the EMPA outcome trial in terms of the cardiovascular risk. And this curve starts separating very early. That is within 6 months of giving, right? They typically separate. Also remember, empagliflozin is helpful in various phenotypes of heart failure. So you can give it in heart failure with reduced ejection fraction, with mid-range ejection fraction, and those with with normal ejection or preserved ejection fraction also. So all these cases you can give empagliflozin. It can be used in a broad spectrum in terms of this, right? Again, chronic kidney disease, we already discussed both empagliflozin as well as linagliptin have reduction of urine albumin-creatinine ratio. Up till what eGFR can you prescribe EMPALINA or DPP4 SGLT2 combination? Well, typically, according to the new guidelines, you can give it up till eGFR of 20. Some guidelines say 25, but technically you can give up to eGFR of 20. So up to eGFR of 20, you can give EMPA plus LENA combination. Okay. So this becomes a broad in terms of advantage. In terms, you can give it up to a much, and it will do a renal protection up to that eGFR as well, right? Okay. What about then contraindications? Okay, which patients would you not give this combination? So obviously, pregnant women or other things. So pregnancy, there is no safety established. So you'll obviously contradict. You'll obviously not give it in type 1 patient, right? Because you will induce diabetic ketoacidosis. So type 1 patient is a contraindication. Patient with eGFR less than 20, you generally don't initiate this agent, right? I think one more important is patient with history of pancreatitis, right? So especially linagliptin. Of course, very few cases have been reported, but DPP4 inhibitors are known to be associated with pancreatitis. So patient already has a prior history of pancreatitis, you will not give EMPALINA combination, right? So these are cases where you will be having typical contraindication. Okay. So linagliptin, I already told you that in the linagliptin trial also you had reduction in urine albumin-creatinine. In fact, somebody asks you, which is the only DPP4 which has shown urine albumin-creatinine reduction or reduction in the progression of albumin progression, it is linagliptin. Linagliptin has, in its trial has shown this to be an advantage on its own. So these are some benefits, right? So I think EMPALINA is a very good combination. Again, you can see the ideal alliance, right? So you have the body weight reduction with SGLT2, whereas DPP4 is weight neutral. You have blood pressure reduction with SGLT2. You have uric acid reduction with SGLT2. You have cardiovascular benefits. Again, this being neutral. You have hospitalization for heart failure. You have reduction in mortality, renal outcomes, and albuminuria progression you see in both these cases, which makes it an ideal combination. Okay, what do the guidelines suggest? So if you see the ADA guidelines say that if the patient has a prior history of ASCVD or high risk, so the case we discussed, if you remember, it was 50-year-old patient with history of coronary artery disease in the past, right? So in such cases, you can give SGLT2 inhibitor right at the beginning, right? And of course, so right. And again, same thing from so KDIGO guideline. We already discussed the up to what eGFR can you give, right? And remember, linagliptin is a drug where you can give it across any eGFR. But when you give EMPALINA as a combination, you can give it up to eGFR of 20. Okay. So which are the patients who can benefit from a EMPALINA or DPP4 SGLT2 combination? So patients with high HbA1c, patients with history of cardiovascular disease or heart failure, treatment naive patients in whom metformin is contraindicated, patients uncontrolled on metformin with HbA1c more than 8.5, patients with diabetic and CKD, and those who want to promote weight loss with no increased risk of hypoglycemia. So to summarize, I think overall, it's a very important concept that you have to understand that poor glycemic control, we have a lot of patients with poor glycemic control, and sometimes monotherapy is not enough, so you have to add an additional drug. I think a good idea is to give a combination of a SGLT2 with DPP4, something like an EMPALINA, where you have single drug, significant HbA1c reduction, as well as you have other benefits also in terms of pleiotropic benefit. Right? So I thank you for a patient listening. Thank you.